more women die of heart attacks than men.
Wow. The symptoms that a woman might experience when having a heart attack are vastly different, it sounds, than what a male might experience.
A woman can experience the classic symptoms, but for a very long time, we called those symptoms atypical symptoms.
Does AI make you optimistic about the future of diagnostics as a provider?
AI certainly makes me optimistic. How can we, as physicians, use AI as tools to complement what we do? For decades, we were told that ADHD disproportionately affects boys. That is not the case. What is the case is that girls with ADHD present with different symptoms.
So is it more common that girls and women will be misdiagnosed than men?
100%.
Do you think we have an overprescription problem in this country?
I think we have a problem with wanting to solve a patient's issue as fast as possible.
Is there anything that we're currently doing today that you think 5-10 years from now we're going to look back and be like, that was insane? Dr. Erin Nance, welcome to the show. How are you doing?
Oh, thanks. I'm doing incredibly.
Oh, it's great to have you. I'm excited for the conversation that I think we're about to have about medical mysteries and the challenges with getting the proper diagnosis and how frustrating that could be. But let's just dive right in. For people who feel deep in their heart that something is wrong, but their doctors can't seem to figure it out. They continue to parrot, "You're fine, you're fine. The labs say everything is normal." What should those people do?
Well, number one, I think, is to understand that you should always trust your gut, okay? There is no one who understands your body better than you. And in most cases, if you are having a significant change in your body, right, there is something you feel is not right, and you are going to doctor after doctor, and they're telling you you're fine, it's not that you're fine, it's that they haven't found out what's wrong with you yet.
Yeah, but sometimes it can be, that can be really frustrating because getting an appointment is difficult. Often, you only get 15 or so, whatever the average is, 15 minutes, you know better than I, in with your average primary care. Visits are expensive. There's often, a form of white coat syndrome where when you're in that office, the clinical environment, it's like all of your thoughts escape and you become tongue-tied and it's very confusing and it can be very frightening. So do you have a playbook for people?
I like to think of, when you think of what is wrong with you, how we solve that problem is through pattern recognition. Okay. This is, as doctors, this is how we are taught how to make a diagnosis. Okay. Patient comes in, they are a 50-year-old man, they are having shortness of breath, they feel like an elephant is sitting on their chest, they're sweating. What's the diagnosis? It's a heart attack, right? 50-year-old woman comes into the ER. She says, I don't feel right. My jaw's bothering me. I got this pain in the back of my shoulder. What's the diagnosis? It's also a heart attack.
Wow.
Okay. What has happened is that because of this lack of research for women, particularly women weren't even included in medical studies until 1993. So most of the symptoms that we recognize as part of a disease are based on male symptoms, male presentation of symptoms, okay? So again, this isn't the doctor's fault, but if they are taught, okay, the symptoms of a heart attack are chest squeezing, feeling like an elephant sitting on your chest, being sweaty, shortness of breath, that's who in your mind is having a heart attack, right? If you close your eyes and you think, okay, who is someone who's having a heart attack? It's Mr. Big on the Peloton, right? But more women die of heart attacks than men.
Wow.
So this is information that we know is out there, but it's not part of just the general,
It's not common knowledge.
Correct.
So women, the symptoms that a woman might experience when having a heart attack are vastly different, it sounds, than what a male might experience.
A woman can experience the classic symptoms, but for a very long time, we called those symptoms atypical symptoms, okay? When in fact, they're not atypical at all. They're actually just how the symptoms present in women. And that kind of thought process can be repeated for pretty much any other disease. We won't know until we do the actual research and collect the actual data to understand, okay, here's another great example. Close your eyes. If I tell you, what is the picture of someone who has ADHD? It's a little 5-year-old boy, right, in the kindergarten classroom who can't sit still, who's running all over the place, all right? And for decades, we were told that ADHD disproportionately affects boys, right? That is not the case. What is the case is that girls with ADHD present with different symptoms. Those girls are spacey. Those are girls who can't keep their desk clean. Those are girls who, try 100 different activities and just can't find, one that's right for them. So again, because we focus this research primarily on studying boys and men, we just weren't able to capture the symptoms that we're presenting in women. And because of that, we as a medical field have pattern recognition failure.
Wow, I feel for girls and women. So is it more common that girls and women will be misdiagnosed?
100%. So in your lifetime, 1 out of every 3 people will experience a misdiagnosis. All right, but women are 5 to 6 times more likely to have a misdiagnosis. And again, it's not necessarily because you're going to your doctor and they are intentionally not trying to help you, right? We talked about this earlier. Sometimes these appointments are 5 minutes long. That is not enough time to even gather the information from you that would help a doctor create, a differential diagnosis in their mind. As of now, the system is built for volume and not accuracy. And so the original question you asked me, how can people actually get a diagnosis, and it's really frustrating. The best thing is to try and make a connection with a doctor who is curious, okay? They are curious about your case. They may not have the answer, but if they don't know the answer, they're going to say, you know what? I have a colleague who is an endocrinologist. I want to tap him in and see if we can figure this out together, which is a much different way of presenting it as, well, here's a referral for an endocrinologist. Good luck, right? It's not about just dumping these patients on other people to try and, put them on the next hamster wheel of specialists and whatnot.
Yeah.
It's working with that quarterback, right? And I call them the North Star, providers, who's able to at least guide you in this process. And those North Star providers are getting harder and harder to find because primary care as a industry is dying.
Is there anything that a patient can do to help their primary care provider during this process of discovery?
Yeah. I feel that the best interactions are when a patient comes in as informed as possible, right? And how to do that is first understanding what is going on in your body, right? By tracking your symptoms, by writing journals, just so that you have a good organized way of expressing what is off with you. And then I tell people all the time, and probably doctors will give me grief about this, but I tell patients to go onto social media, but to use it not to self-diagnose, but again, to recognize the patterns of symptoms in other people's stories, right? People, they communicate with one another best through storytelling. And TikTok, I know a lot of people my age think of it, oh, these are like dancing kids, they're funny dog videos. People are sharing stories. And when it comes to your health, right? They are sharing their symptoms, their diagnosis treatment, their providers, all through these stories. It's not to say that you are going to have the same problem as someone you saw on TikTok, but for many people, for the first time, they go, that's me. That sounds exactly like me.
It's wild. But isn't there a risk to consulting social media? There is the spread of, I hate using the term misinformation because it's like whatever information I don't like has now gets the label misinformation. But there is a lot of like low quality information on social media, and then consulting Dr. Google can just freak you out.
Correct. And I have made over, I think, 1,200 videos on TikTok as Little MisDiagnosed, and I have spent a lot of time online, and I think that the physicians who are online do an incredible job. But the problem is that those same platforms are the source of the misinformation, right? So what's a patient to do? It's part of why I built this platform called Feel Better, which is, think of it as like a go-to source for medical social media, where you know that all the content comes from vetted, credible medical experts. Because in the end, your symptom comes on at 2 a.m. on a Tuesday morning, right? You're not going to talk to a doctor at Tuesday at 2 a.m. Where are you going? You're going to your phone, right? And you're trying to find something that, again, you can do to help yourself on Tuesday at 2 a.m. Well, at least we can provide people with a space that's a safe and trusted place to get credible health information.
The other day I had a thing come up where, for whatever reason, one of my little toes just was like killing me. It was like throbbing with pain. It was like, and I didn't know where to go. I was like, I actually consulted AI. I was like, is it like my toe hurts? It's not a life or death situation. Do I go to the emergency room? Do I go to urgent care? Am I supposed to make an appointment with a podiatrist? I've never seen a podiatrist in my life. Like, what's the problem here? Do I have an ingrown toenail? What is it? I ultimately didn't do anything, and it completely resolved on its own within 48 hours. But there was a good 48 hours where like my toe was killing me and I had no idea where to turn.
I will tell, and listen, I get thousands of DMs and emails a week from people telling me their story and their misdiagnosis story. I have become the de facto, expert on misdiagnosis. And I will tell people to use ChatGPT to put in their symptoms and ask for a 5 differential diagnosis. Okay? Because you don't want ChatGPT telling you what you have. Okay? What you want ChatGPT to do is put you on a path to do better targeted research. Okay? So if ChatGPT told you, well, it could be an ingrown toenail, it could be a stress fracture, it could be a fungus, it could be necrotizing fasciitis, right? All of those, none of them sound good, but right. You can probably think like, okay, it's probably not necrotizing fasciitis. Maybe it's a stress fracture. I never considered that before. Maybe it's just an ingrown toenail. That's something I've dealt with before, a nothing burger. But again, it kind of gives you the different pathways to say, you know what, this sounds more like me. And then what I will recommend people to do is go onto social media. You can either in the search bar or just, the algorithm is so good, it probably knew you had a bum toe when you started scrolling. But then watch other people talk about what an ingrown toenail is like for them. Listen to other people talk about what a stress fracture in their toe felt like. And again, the whole point is to use the power of social media to empower you to have a better conversation with your doctor.
I love that. And doctors use these tools as well, right? Like doctors use Google all the time. I feel like if you're a physician and you're not at this point using AI, you're going to be ultimately left in the dust.
We, in essence, have a cheat code that most people are probably not aware of. There is an AI platform called Open Evidence, and it is a platform you must be a physician, you have to have an NPI number to access the site. But what it does is we can ask any clinical question and it will use AI only drawing from the resources like PubMed or JAMA or New England Journal of Medicine to answer that clinical question.
Whoa, I need to get in there. I need to find somebody to give me their code.
Yeah. So it's an absolutely incredible platform. However, you have to understand that it is only drawing from the data that has been published. So going back to our original conversation about the lack of research in women, right? It's going to just tell you the data that we know about heart attacks which is primarily talking about symptoms in men, right? So there are blind spots and there are bias, to our research. Even things like all the medications and the pharmaceuticals, right? Those pharmaceuticals were tested primarily on healthy male subjects, right, who have a particular BMI. So it's not surprising why if you have a 4'10" woman who a certain medication is not responding in a way you would expect, it's because that was never tested for someone like her. So as we're moving more towards this era of precision medicine, I think it's wonderful to have solutions that are tailored for the individual, but you have to be careful because you also have to test these drugs and these new treatments on a very large scale so we can capture the potential side effects and adverse effects.
Yeah. Do you think one day misdiagnoses are going to be a thing of the past, what with the tools of AI and all? I mean, like, does AI make you optimistic about the future of diagnostics as a provider?
AI certainly makes me optimistic. I will say, as the current system exists, the physicians, we are still the gatekeepers, right? We are, in essence, the bottleneck a lot of times for people getting the care that we need. And why is that? It's because the resources are limited. The resources are scarce. If we let every individual get an MRI, right, we don't have enough technicians to run the MRIs. We don't have enough radiologists to read the MRIs. Now with a lot of how we're implementing AI, we're using the AI to read the scans, and the radiologists are just kind of double checking the AI's work. So things can evolve, but in the end, AI is not going to draw your blood. Okay, AI is not going to give you a cortisone injection. AI is not going to do your carpal tunnel release. And I think it's more about how can we as physicians use AI as tools to complement what we do.
Yeah. Is one more likely to be misdiagnosed in a private practice clinic versus in the big hospital setting?
Well, when you think back to just medical communication, right? Back in the 1900s, you had the family doctor who was doing a house call. They were physically showing up to your house, and they weren't spending 5 minutes with you. They were spending hours with you. They were, and this is also part of the trust, they knew who your parents were, they knew who your kids were, they knew, what job you had. But part of that interaction was they were gathering thousands of data points from that conversation. And part of the job of a doctor is being able to synthesize all of those data points into one potential diagnosis, right? So that's how medicine, started. Then in like the 1950s, medicine became more institutionalized, right? You went to the office. You saw the doctor in their office for, 30 minutes. Now, again, when we talk about the system of medicine, each primary care doctor probably max has, 30 minutes for a new patient and then 10 to 15 minutes for a follow-up. And if you are a complex or chronically ill person, that is just not enough time. It's not enough time to even share the story of, what you're feeling or how this happened. So I am really optimistic about utilizing those AI tools to help us work within our system, but what I'd really like to see is a better evolution of the system.
Yeah. Does it help women to have a female physician? Like, does that help reduce the likelihood of misdiagnosis?
Well, there have been studies that have shown that, I know because I'm a surgeon, female surgeons have better outcomes and less adverse events than male surgeons.
Interesting.
Okay. And to be honest, I don't remember if that was broken down for female patients and male patients, but I think if you just ask any female patient, they are just much more comfortable and confident in their interactions with a female doctor. It's not to say that all female doctors are able to diagnose everything. I have misdiagnosis in my past. I don't get it right every time when I see patients in my office, but I will say that if I don't get it right, I am able to acknowledge, right, that I didn't get it right. I have this story of this patient who came to see me. She was on her phone for a long time. She's like, oh, my thumb really bothers me. She had seen another doctor. They had given her an injection for a trigger finger, which is super, super common, but it didn't help. So when she saw me, I said, well, I don't know how that doctor did their injection, so let me try to do my injection. I injected her thumb. She got a little bit better, but still not really. So kind of the next step on my diagnostic rubric is, okay, now we're going to move to a trigger surgery. And so I do the surgery. She gets a little better, but not really. I really did not solve her pain. So then I said, okay, maybe I missed something. I'm going to send you to my colleague who's a spine surgeon. Make sure you don't have, a neck problem that's radiating down to your thumb. He looked at her, he said, it's not her neck. I don't know what's wrong. We thought, okay, maybe we'll send her to the Mayo Clinic. Maybe she has something super rare. So, we help her set up these appointments. And in the end, what she ended up having was this condition called Ehlers-Danlos syndrome. We were talking about this earlier, but it's a condition where the collagen is defective, and so her joints are just too flexible. And so it was actually a genetic problem. It was not the normal, trigger finger issue that people who don't have Ehlers-Danlos. And so I missed it. I totally missed it. And here I am, I'm, the misdiagnosis queen, and I missed this diagnosis. But then I was able to talk to her and say, listen, I think actually this was a missed diagnosis. I think you have something called Ehlers-Danlos syndrome. And then once we got talking more and more, she's like, oh my gosh, I've been diagnosed with IBS my whole life, but no, this is part of the Ehlers-Danlos.
Wow.
Right? So I was able to help connect a lot of dots to this one diagnosis, but you're only able to connect the dots if you collect the dots, right? So I'm taking time to ask my patients, even though I'm a hand doctor, I'm asking, have you ever had, issues with your gut? Have you ever had problems, rolling your ankles? Were you ever diagnosed with scoliosis, right? I'm asking about a lot more things than just a normal hand surgeon would ask about.
What are some other weird conditions, some of the more weird conditions you've encountered?
Well, I just finished the story for my podcast last week that came out, but this was a fascinating story of two friends who met on TikTok online because one woman shared her misdiagnosis story. She was misdiagnosed with a condition called slipping rib syndrome. And both women had the same story. They were fine, and then one day she was walking her dog, and the dog ran in the wrong direction, and she twisted her body, and then she physically said, it feels like my rib is stabbing me.
Whoa.
Okay? And she went to all these different doctors, and they said, you're fine. There's nothing wrong with you. No, that's not possible. And it got to the point where she just kind of gave up. Right? She's like, I guess there is nothing wrong with me. If 20 doctors can't figure out, right? I've been to the ER, the urgent care, the neurosurgeon, the orthopedic surgeon, the physiatrist, the PMNR, the endocrinologist, the psychiatrist, right? And nobody can find anything wrong. Well, I guess there's nothing wrong with me. And again, it goes back to if you feel like there is a change in your body and something is not right, it is not that there is nothing wrong with you. It's that they just haven't found out what's wrong with you yet.
Yeah.
And so when she saw this TikTok video of this other woman, the same exact story, and her story about not being believed and finally getting diagnosed with slipping rib syndrome, she's this light bulb moment, right? She's like, that is what I have. Now, it's not good enough just to find another person on TikTok and say, okay, that's what I have, right? You still have to go through the official channels to get the care. But her story, which made it even more fascinating, was she was from Canada, and there was not a single doctor in Canada who could treat her for slipping rib syndrome. She had to fly all the way to West Virginia to come and get that surgery. So yes, things can be, and I say this all the time, rare conditions are not rare. They're just rarely diagnosed.
Wow. I was looking on your Instagram, and you were talking about no burp syndrome or unable to burp syndrome. What the hell is that?
So this is, again, something that I first learned on social media. This is a syndrome that affects the esophagus, and there is a muscle that lays on top of the esophagus, and it prevents the air from leaving your esophagus. Now, I'm going to butcher the name of the actual, but it's like retrocricopharyngeal syndrome. Okay, something
Sounds
crazy.
legit,
okay?
yeah.
It needs a rebrand. All right, and they did. They rebranded it to no burp syndrome because that's what actually people felt all their life. All these people were never burping. Okay, but if you go your whole life never burping, you may not realize that that's actually not normal, right? Okay. And when these people started posting online that they had this no burp syndrome, one, people are like, oh my God, I have that too. But then number two, there are treatments for it. And so it went from this condition where it just kind of was this like oddly named thing that nobody had no idea. It was kind of, I don't know, but there are repercussions to not being able to release air from your esophagus. And there are treatments for it. So something like that, where you can use the power of social media to, again, scale that knowledge. But the point is not to go around saying, I've got no burp syndrome. It's to then go to your doctor to say, hey, these are the symptoms that I saw, you can say TikTok, but they'll probably give you a side eye, that I saw. Do you think I could have retrocricopharyngeal syndrome, right? And to be fair, that doctor might have never heard of that, right? And if you have one of those North Star providers, they'll say, hey, I don't know what that is, but let me look into it, figure out if that's something that you may have, and then let me get you to the right person who does treat that.
One of the weirdest conditions I've ever heard of is auto-brewery syndrome. Are you familiar with that?
No.
That's crazy. It's where your gut microbiome becomes essentially a fermentation factory. And, you consume certain types of fermentable carbohydrates, and the microbiota pump out ethanol. So you basically develop a beer brewery, essentially, in your gut.
Well,
and it makes you drunk.
There's a condition called SIBO, which is a bacterial overgrowth in the gut, which is probably along the lines in the same kind of category of problems. But yeah, and I tell this to people who follow me all the time, there are some diagnoses that are really just descriptors, okay? And that just means that when you have a diagnosis, you're just describing what is wrong. It's not actually helping you get to, and I don't like to use this term, but the root cause of the problem, right?
Why don't you like to use that term?
I don't like to use that term because I feel like it has taken on a different meaning in the just like popular vernacular. I like to call it the disease origin story because that's really what we're trying to get to, right? You could say, for example, okay, you've got, a yellow fingernail. All right. Oh, you've got, and I could call that, I can make up the Latin term for it, for like Latin fingernail, for, yellow fingernail. But what caused that yellow fingernail is a fungus, right? So I could say, oh, you've got yellow fingernail. But if I don't know that, oh, this is this particular type of fungus that caused that yellow fingernail, I'm never going to be able to treat it properly, right? We're just going to take your fingernail out and you're going to get a new fingernail. No, if you actually put them on antifungals, that is what's going to solve the yellow fingernail problem.
Yeah. I agree that the whole root cause thing, on paper, it makes perfect sense and is totally something that anybody would want to get to, but it's sort of used to, I think, divide traditional allopathic medicine from functional medicine, which I think there's a lot of good to come from functional medicine, but there's also a lot of over-testing and stuff like that.
Absolutely. I really feel that for a lot of patients who they get flack for using a functional medicine doctor or using alternative, treatments or therapies, the vast majority of those people, they don't start there. Right? They start trying to solve their problem with a doctor through the traditional medical panels, and they're being failed, okay? And usually that is what pushes them over to trying another method. And, if a patient comes to see me and they have carpal tunnel syndrome and we've done 2 injections and the next step is a surgery, and they say, you know what, I'd really like to try acupuncture. I tell them, knock your socks off. Okay. I know that acupuncture is not going to harm them. And if it does in some way make them feel better, that's great, right? Not everything that we do as traditional, and I am still a practicing surgeon. I 100%, believe in traditional, Western medicine.
Of course.
But I feel strongly that there are other ways for specific people, right? And it may not be that all of our ways are necessarily the best for that individual.
Yeah, I'm a huge fan of what do you call it, traditional Western medicine. I mean, I had spine surgery 7-8 months ago at this point, and it's changed my life. I had artificial disc replacement at L5S1, and then 2 years ago, I had a medical mystery of my own. I developed Horner syndrome, and we did all the tests. It was obviously like a big freak out moment when at the onset, but then we determined that it was associated with migraines, which I get. Not all the time, but I get occasionally. But yeah, I developed this I guess it's rare. Most of the physicians that I encountered during that period were like, yeah, it's a pretty rare, I've never actually seen Horner syndrome, even though we learned all about it in medical school.
But that, I would challenge you, was rare to that doctor, right? They have never seen it in their practice, but there's probably thousands of people, tens of thousands, maybe even hundreds of thousands of people with Horner syndrome. And so, for example, if you probably would put in Horner syndrome into TikTok, now this is one of the shortcomings of TikTok, right? You don't know the background of these people posting the content. So you may find a lot of helpful information from someone describing their own story of experiencing Horners versus a neurologist talking about Horners. Right. And that's, part of the Feel Better platform is I think that we need to value both the physician expertise and the patient experience, right? Because if someone came up to you and they were newly diagnosed with Horners, you would be more than happy to share your experience, right? With how it happened, what you did, these were the people you saw, this was helpful, this was not helpful. And that's not to tell people, okay, you should do this, you should, do that. That's for you and your physician to have that conversation, but at least gives them a starting point. It at least gives them a little bit of reassurance, like, wow, he came out of it on the other side. And that's where I think the power of social media in talking about these rare diseases is really helpful. And even it's helpful for educating the physicians, right? I learn so much on TikTok that, again, maybe I had one lecture in med school, right, about Horner syndrome, but I'm a hand surgeon, right? I haven't dealt with Horner syndrome in, 20 years. And part of that is intentional, right? I am a microsurgeon. I am like a surgical ninja, all right? If you, for God forbid, chopped your hand off, I could reattach your hand.
That's crazy.
All right. In order to do that, I have to be so dedicated to my craft and all of these hours to learn how to do that, right? I don't have time to research about Horner syndrome. So the silos that exist were, in essence, no one was able to transplant a hand 100 years ago.
Right.
Right. So these silos exist because there's been an explosion, right, of treatments, of specialties, but the cost is looking at people as a whole body person.
Yeah, so I think that's where functional medicine becomes, or the promise of functional medicine becomes seductive when people find that they've been, spinning their wheels going through the traditional system. I mean, there was a great South Park episode a couple months ago, or maybe it was even a year ago at this point. I think it was about the GLP-1 drugs, where Cartman goes to try to get one of these drugs prescribed. He's obviously an overweight child. He's depicted as such in the show, and there were all the hoops that he had to jump through, back and forth with their insurance, getting it cleared. So, I can imagine that for somebody who, feels tired of not being seen as a whole entity, that functional medicine, in terms of how it's marketed, I mean, that's the promise. But again, there's, I've definitely seen over-testing. I've seen, it foment this sort of hypochondriac mindset about health. It can be very expensive and cost prohibitive. So yeah, I mean, I super appreciate this. But of course, when in the throes of a new onset condition, I mean, you want to get the best medical care you can.
Listen, people are desperate at that point. And a story that my dad tells, my dad is a healthcare attorney and used to teach healthcare law to his students. And he would say, okay, poll the people in the class, what car are you driving right now? Like, I have a Honda Civic, I have an Acura, I have, a Beetle. And he'd say, okay, when you are diagnosed with cancer, where do you want to go? I want to go to Memorial Sloan Kettering. I want to go to Cedars-Sinai. I want to go to, the Mayo Clinic. Well, insurance doesn't work like that. You have Honda Civic insurance, right? You don't have Mercedes insurance. And that is the reality of how insurance works today, right? But as a person, I would say, I want to do everything in my power to go to the Mercedes of, cancer centers and get that done. So again, this goes back to the systemic barriers that we have put in place that really just hinder us living our healthiest lives.
Yeah. Well, the sort of like capitalistic nature of healthcare in this country. I mean, on the one hand, like, I'm for it in the sense that, like, yeah, not everybody's going to have access to the same care, the same way that not everybody has access to the same quality of food. It's unfortunate, but it's like, we don't live in a homogenous society where we have equal access to everything. Like my own personal story with regards to my back surgery, like, insurance covered a certain proportion of it, but I had to go out of pocket for the majority of the cost, and it was super expensive. And I don't know if insurance. Well, my provider doesn't even take insurance, and there are reasons for that, right? For physicians to shun that model. Part of it has to do with the care that many physicians have for their patients, right? Because the traditional model just doesn't give them enough time.
Yeah, I have always been an out-of-network doctor, and my story is I started my own practice straight out of fellowship, which is almost unheard of now. It's economically insane to do that. But when you start as an individual, like, I literally hung my shingle, right? I hung my shingle on the door. When you have to apply to be in network. And so I applied to be in network for all of, Cigna, Aetna, United. Okay, they didn't want me. They didn't need me. Okay, because I was just a single solo doctor. They had plenty of other hand surgeons in their network. So I was never allowed to be in the network. And that's how I started being out of network. Then once I was in a couple of years, and now the insurance companies, I had, a large patient population, they said, oh, well, we'd love to have you in the network. When I saw the reimbursement that they would pay me to continue seeing those patients, I go, this wouldn't even cover my overhead. I would, in essence, have to be subsidizing the patients that I'm treating. It's not tenable. And I can get into the whole history of healthcare reimbursement and whatnot. But in essence, 30 years ago, we as doctors allowed health insurance companies to determine the worth of our services. Okay. I trained at the Hospital for Special Surgery, the world's best orthopedic place in literally the world. It's not to say that I'm necessarily better than someone who hasn't trained, in that capacity, but I value my work certainly more than what Cigna is telling me my worth is worth.
Yeah, of
my
course.
work is worth.
Yeah. Mm-hmm. I mean, I think that there's obviously, we live in such an affluent society here, at least in the United States, that, for emergent care, I think that and I have not thought too deeply into this, so I don't know how it would work necessarily, but I'm assuming that it's working somehow. That if you get hit by a car and you don't have the resources to pay for an emergency room visit, you should be able to go to the emergency room. But on the other hand, I think with the nature of the proliferation of ultra-processed foods and the bad choices that people make for themselves, to, from a societal standpoint, subsidize the cost of conditions that are basically lifestyle mediated, like I think that would be, hugely problematic. I was just in Denmark, and the culture there, I mean, everybody's extremely healthy. Everybody bikes everywhere. I didn't see any smoking while I was there. I mean, they consume a lot of ultra-processed foods, but I didn't see any obesity. And they have essentially like a democratized, like socialist approach to healthcare. And the society is totally homogenous. And, everybody's biking, as I mentioned. And there, I think it makes a lot more sense. But in a country like the United States, I just think it gets a lot more complicated than that.
I mean, something as simple as like my daughter's on this travel soccer team, so we're traveling to a lot of different areas that I've never been to before, and usually we're grabbing like lunch on the go after a game. And I remember we stopped. It was a Hispanic deli, and I went to look at the drinks that they had. And I don't want to mention the brands; I don't want to get them in trouble. But I picked up one of the drinks, and I just looked at the nutrition
Sugar
information,
content, yeah.
The sugar content, it was like 300% of your daily allowance of added sugar, right? And all these people in this deli pop in like it was nothing. And again, it goes back to like, what are the choices, the individual choices that we are making? I think the government can make that choice a little more obvious, right? and have input into that. But yeah, a lot of it we are doing to ourselves.
Yeah.
We're doing to ourselves.
Amen. What do you make of sometimes you hear these statistics float around on social media that are frankly quite shocking with regards to iatrogenic harm. So the harm, sometimes there's this I guess it's like I don't know where the data comes from, but one of the leading causes of death in this country is from medical care. Is that accurate? What might that be attributed to?
There have been studies which this quote gets thrown out, but medical errors comprise the third biggest cause of morbidity and mortality, meaning death and serious harm in the U.S. Now, it's very difficult to actually trace that back on an individual basis, but medical errors are being made all the time, nonstop. Okay, and it's one thing, right? If it's okay, I was operating on a patient. They had a bowel tear, and I went in and I tried to fix it, but we couldn't get it to stop, and they passed away anyway. And even though we tried, we gave them a different bowel tear and everything. Like that stuff happens. That is different from systematic errors and problems, right? So, for example, central lines. All right, central lines are when a patient is very sick and they need to have a large portion of IV fluids or medications put in a large vein, okay? The process to do it is you clean off the skin, you put in the needle, you thread this very long wire, you thread this long catheter down into the heart. There was a point in time where people were consistently getting these central line infections, okay? And when it happens to just the one patient, like, okay, we put them on antibiotics, we switch them to a new site. Okay, well, then another patient a week later gets a central line infection. Okay, we're going to take that out, we're going to put them on antibiotics, and they're going to leave. And then the next week, another patient gets it. Okay, when you treat it on that individual basis, you're like, oh, okay. But what we didn't realize that systemically there were errors, right, in place to doing the right cleaning process, towards recognizing a problem when it starts first. So that's when the government stepped in and said, okay, we're going to institute these rules for how to put in central lines to limit the amount of medical errors. All right. Do you ever wonder why when you go get a surgery now, you see the doctors, they're big John Hancock, right, on your right wrist. Okay, where you're having surgery, your right wrist. It's the right wrist. Okay. Why did that happen? It's because there were thousands of people who had wrong-sided surgery.
What, thousands?
Oh, more than thousands. Thousands per year. All right. And it wasn't until probably about 15 to 20 years ago, there was a landmark study called To Err is Human. And it really looked at these problems from a system-wide focus. And so that reason why we do the signature on, the right wrist, the right finger, the right knee, it's part of what we call the universal timeout. And we took this from the aviation industry. All right. Before any pilot starts the plane, they have to go through this checklist, which means, okay, the door is sealed, the windows are shut. Okay, right? It's this checklist. Similarly, now we by law have to go through the surgical checklist. This is the patient's name. This is their date of birth. This is the side of the surgery. This is the name of the procedure that we're doing, right? That is to try and stop any wrong-sided surgeries. And it had tremendous effect on decreasing the amount of wrong-sided surgeries. Now, it took time, right, because this was a behavioral change in surgeons, right? Surgeons don't want to waste 1 minute. So I remember even in the beginning, most surgeons, they'd be like, oh, the timeout, they weren't on board with why we were doing this. But now you would never do a surgery without doing the timeout. You would never do a surgery without confirming the initials on this side of the hand, right? But that took, again, like public health-wide, system-wide processes that are meant to protect the population.
That's crazy. Is there anything that we're currently doing today that you think 5-10 years from now we're going to look back and be like, that was insane?
I think a lot of the cancer care, even now, I had one of my followers was talking to me. She was recently diagnosed with breast cancer. And in my mind, because I don't deal with breast cancer, I'm like, okay, you have the surgery right away, and then you're on chemotherapy, maybe radiation. But no, her process was she started the chemotherapy first to try and shrink the tumor as much as possible, and then they went in and do the surgery. So even getting back to what you said about how you don't like the term misinformation, which I also do not like the term misinformation, science is meant to be evolving, right? We are meant to make choices with the best information that we have at the time, but then continuously question them and question, is there a better way, right? Is there a better way than just completely chopping off women's breasts, right? That's what a mastectomy is. At this point in time, it seems like, yes, this is, right? This is why women go through preventative mastectomies, right, who have the BRCA gene mutation. And at this time, with the research and the knowledge that we have, this seems to be the best way. But 5-10 years from now, I don't know. Is there going to be a better way where we don't have to do that? In my field, there's a tumor called osteosarcoma. And it generally happens in like teenage years and around the large joints. So the knee is really the most common. And 20 years ago, if a child was diagnosed with osteosarcoma, we amputated at their thigh, right? A kid just without a leg. Great. Now that was done to protect the child from having that cancer affect their body and die, right? We're trying to help them live. But now our techniques have evolved that we can do something called limb sparing surgery. And we're able to dissect out the tumor while keeping the essential parts of the leg still intact so that they're able to have a functioning leg.
Amazing.
But that technique was not available, 20 years ago. So my hope is that we continue to question, right? We continue to be curious. We continue to think, is there a better way? And that's really what basic science research and why there's so much concern about what's going on, about all of the cuts to research and basic science research. We don't get to that limb sparing surgery just overnight, right? That happens over years with working with animal models first, right? In clinical trials. These are things that need to be researched before they are adopted for, again, the public. And we do this so that we can make these recommendations with a certain level of confidence because we need the patients to trust us. All right. So to me, it goes back to investing in our science as a system, in healthcare as a system to get the best individual outcomes.
It's so true. Science asks questions, it doesn't silence them. But sometimes, there's that famous Max Planck saying, quote, that science unfortunately advances one funeral at a time due to the obstinate personalities of people that tend to gravitate toward academia. And I think I'm 100% unequivocally, I agree that we need, all the research, all the money, all the research dollars in the world. But also, there's this old guard, that I think can sometimes act as a barrier to progress. I was getting into it on social media recently because there was a study that was just published last year. It was a huge study, and it wasn't the first of its kind, showing that, in general, girls are getting their periods earlier. Not dramatically earlier, but there is this phenomena where, menarche is occurring earlier than it had in the past. And I think a lot of that has to do with the fact that, first of all, we've solved the undernutrition problem. So we've solved the food scarcity issue. But now, for the first time in human history, there's a higher risk of overweight than underweight in children and adolescents, and also in adults. There are more overweight adults walking the planet today than there are underweight, and that's a novelty on the historical time frame. And so, the early menarche, it started to advance earlier and earlier as, we solved for the nutrition problem. But now we have an obesity problem, which is making that occur, even earlier. As you know, I'm sure adipose tissue creates estrogen, and 20% of children now are obese, not just overweight, but obese. And so I was getting into it with somebody because it was brought up by RFK Jr. at a press conference recently. And I think he got the numbers wrong. He said that it was something like it's occurring 6 years earlier, which is like a gross overstatement. But nonetheless, similarly, like to what happened with the Tylenol stuff, it was taken as some sort of political statement, and these people who are just like anti-RFK, anti-anything the current administration does, they fixated on that number that RFK said to distract from the fact that this actually is a problem. And I just thought it was so sad that we can't even have these conversations because everything today has become so politicized.
I mean, I just got back from the University of Hawaii, helping to bring their researchers and clinicians onto the Feel Better platform. And I was talking to the world's expert on microplastics in the placenta. And what was interesting is that RFK Jr. had just given a press conference talking about the effects of the placenta, but he described it in the wrong way. He said that, children are, they form in the placenta, which is just, it's wrong. But again, the fact that there's even mention of the placenta, so I'm talking to the world's expert, and he goes, we need to sound the alarm that we have discovered that there is a incredibly high level of microplastics in the placenta that has now crossed this blood placenta barrier into the fetus, right? So your child is now born with microplastics.
Crazy.
All right. So again, sometimes it's the messenger is the problem. And I feel like if they could just get the message across accurately, that would help. Have accurate, credible, information. But it's a shame that health has become politicized, and we are seeing the effects of this distrust in our public health systems, right? The rising, measles outbreaks and this is a whole nother conversation. But what I think we really need to work on is rebuilding just trust in science and healthcare.
I totally agree. Do you think we have an overprescription problem in this country?
Well, I think we have a problem with wanting to solve a patient's issue as fast as possible, right? And so for many people, for many physicians who are trying to help, right? We're trying to help someone get better. The fastest way to do that is sometimes with a therapeutic, right? With a pharmaceutical. Every drug, I say, you don't get something for nothing, right? And this is where I think the bigger problem with just giving people a medication, right, there are so many side effects and adverse effects that come and may not be apparent, right, as you're taking that medication. So for me, I think we need to work with, pharma. We need more cures. We need better, medications, but we can't just rely on the medications. And I think something that really was helpful with GLP-1s is that it did for the first time for a lot of people who struggled with their weight when they were given this medication and they were able to lose weight. For the first time, it was not seen as a moral failing, right? Oh, you eat just because you eat bad, you don't exercise enough, right? There is a way to medically help you lose weight that I guarantee you people who have tried it all, right? No one who is overweight has ever thought like, oh, no, I'm just going to no, they have tried it all, okay? So I think number one, the use of medication is helpful in kind of saying like, okay, it's not just a moral failing, right? No one who has asthma goes to someone who has asthma and be like, oh, you ran that, race. Well, obviously it's going to exacerbate your asthma, right? No, we want to help people live and live with the conditions that they have to their best ability, right? That's what we should be using medications for. And if we're able, it should be in conjunction with healthy eating, with more exercise. I mean, that same, the time I was at University of Hawaii, they have a massive longitudinal study studying, people, Native Hawaiians, people who have lived on the island for a long period of time. And what they found was how they used to live 50 years ago, because they were farmers, because they were very active, they had such less, disease and chronic illness. And really, it is because of their lifestyle now, right? There is no more sugarcane farming on Hawaii. They have obliterated that as an industry, so it's not even an option for them. But they proved that having that particular lifestyle is a better, healthier lifestyle than the typical lifestyle they are living now.
It's a Samoan population, right?
Yeah, Samoan. And listen, I did a surf lesson, and I was with all these amazing surfing instructors. There is not 1 ounce of body fat, okay, on those surfing instructors. That's not to say that everyone can be a surfing instructor, but again, they created a life where they are physically active. And listen, we need people to be coders, and we need people to, be in retail stores. So I get that it's not possible to live a life, make an income by saying, all right, you got to exercise 8 hours a day. But if there's a way that we can incorporate just more exercise, right? I'm from New York. I walk everywhere. I haven't seen a single person walking on the sidewalk here in LA.
No, it's right? Rare. Yeah, I walk. But
So yeah, it's about just integrating these small things, right? You talk so much about food as medicine and how the choices that we make with our food. That's easy to say when you have the economics to buy organic and to go to the grocery store. And I'm not here to say, Erewhon is the end all be all to get the best, type of produce.
Definitely not.
But a lot of the options for people who are on, subsidized, methods for obtaining groceries, those options are awful. Okay. There's almost no nutritional value to them. So it goes back to what are we doing as a society to implement these smaller things that can have massive impacts on our health.
Yeah, amen. But I think if you are able to vote with your dollars for the system that you want to help usher in, then that's going to help be the rising tide that lifts all the boats. It's now we can get organic, we can get grass-fed at Costco, there's organic at Target, there's organic at Walmart. Not that organic even should be your first priority. I'm not claiming that, but yeah, I mean, I think like just increasing the education around nutrition is crucially important. I think part of what excites me is a future where animal source foods are going to be no longer demonized in a time when 60% of the calories that your average adult ingests comes from ultra processed foods. The fact that anybody is still out there demonizing red meat, eggs, things like that, to me is just a big, huge problem, criminal, in fact. And so and those kinds of foods are, I think, like maybe they're not the best, like, most pristine grass-fed options that are out there. But I've always said that even conventionally produced, a conventionally produced piece of protein is going to be a better option for you than boxed mac and cheese for dinner.
Absolutely. I mean, I try to eat, and I go to McDonald's just like everybody else, but I try and eat where there is no list of ingredients, right? This is lettuce, this is steak, this is a tomato. And when I never used to do this, but I will look at the box, right? The list of ingredients and everything. And I think, and this happened to a lot of women, right? We were fixated on the calories, right? We were fixated on the number of the calories. When, like, if you look at some of these protein bars, right? It's just, they're full of junk.
Yeah.
Okay, there's no nutritional value. So now I really try and focus on even not so much trying to figure out like the bad things, but like, what are the good things in this that I want to be putting in my body, right? Like that's what I'm trying to maximize. It would also be great if there wasn't, trans fat and other things that we know are bad for us. But yeah, I'm trying to teach my daughter, okay, what about this is a good choice? And listen, sometimes, as I said, we are on the go in between soccer games and it's either you're starving or we hop into McDonald's. And again, there's nothing wrong with that. Okay. There's nothing wrong with saying, okay, for, this one day, you're going to have McDonald's, but you're not going to have McDonald's every day. Right. And I think if we approach it like that, we don't, proselytize to people to say, never have, fast food, never have something that's just not realistic. And so if we can say, yes, we acknowledge that there are times where there's going to be things you do out of convenience, things you do because it's cheaper, right? But even within those choices, you can make the best choice available.
Yeah, we can't let perfect be the enemy of the good. Well, this was so fun. Who'd you write Little MisDiagnosed for?
Well, I really wrote it for any girl who wants to go into medicine. My field is orthopedic surgery. Orthopedic surgery is 94% male and has been 94% male for over 50 years. Okay. And I wrote this book as this was my journey going through from an intern all the way to my fellowship. It started my first day of work, and I always wanted to share this story, but I never knew like how I was going to share it. But my first day of work, I'm night float at Lenox Hill Hospital. I just matched into my dream hospital in New York City, and I get a call from my mom, and my brother was in a diving accident, broke his neck, and became a quadriplegic.
Your brother?
My brother.
Wow.
And that was my first day of work. And so I had to leave. I went he was out east, and that I did not expect that to be the start of my medical career, right? Where now I'm no longer the physician, I'm really on the patient side of things. And that incident is really what shaped me as a doctor, how I'm empathetic, listen, I know how things go, and we do rounds at 5 a.m. for a reason because we don't have time to speak to all the families. But I know what it's like to be that family who is waiting with bated breath for the doctor to come into the room, right, to ask the question. And so I would always loop back around and make sure that I made myself available to answer any questions, right, for patients who, for them or their family. But yeah, it's a family story. It's a story about overcoming odds. It's a story about finding your voice when you are in the minority. There are a lot of incidents that as an intern, right, you are on the bottom of the totem pole and you really don't feel like you have any say or any power to make any change. And it wasn't until I got to the top of the totem pole and I was able to say, okay, you know what? I'm not standing for the misogyny that's going on, in this office. But I wasn't able to do that when I was an intern. And I even talk about how part of like the reticence about me talking about all these different stories was because I thrived in that environment. I was a great ortho resident. I love my mentors. I had a phenomenal time. But I kind of played into that system, right? And by me not speaking up, by a lot of these, bad behaviors that were going on, I was just making it harder for the next woman to speak up. And so I really wanted to, get this out there to help other women feel like, you're not alone when you find yourselves in these situations, and to understand that you will find your voice, you will make a difference. You just have to find the right time.
Wow. Is there a story behind your decision to focus on the hand?
Well, this is how I knew I wanted to be an orthopedic surgeon. So my dad, who I mentioned was a healthcare lawyer, he worked for Lenox Hill Hospital. When I was 7, I tripped down the stairs and I broke my arm. He brought me into Lenox Hill and I was waiting for the doctor, and in walks a guy wearing a tuxedo. It's like, what is going on? And he examines me, he puts the cast on me, he sends me home. I was like, what? What just happened? Like, did James Bond just come in and fix my arm? And it wasn't until years later that I learned that my dad had called one of his friends who was an orthopedic surgeon at the time at Lenox Hill. He was not the doctor on call. He was at the opera on a date with his wife, and he left the opera to come and fix my arm. And I just always wanted to be like him. I wanted to be like Dr. Alexiadis. And that's kind of what kickstarted my love of orthopedics, and in particular, the hand and the arm.
Wow. So cool. What a story. Well, this was so fun. Thank you for coming out. I've got one last question for you, but before we get to that, where can people connect with you on social media? I know you've got all these cool resources for people, and you're an avid content creator yourself. So yeah, maybe drop all the handles and the places that people can support.
Yeah, of course. So my main channel is on TikTok. I'm at Little MisDiagnosed. That's also the name of the book. And then I have the Medical Detectives podcast, which is really a patient storytelling platform for people who have been misdiagnosed. Again, I allow them to find their voice and share their story. And then for everyone, I am building the first social media platform dedicated to health. That's called Feel Better, and it's really the go-to place to get credible medical information from vetted medical experts.
Amazing. I look forward to that. The last question that gets asked to everybody on the show: what does living a genius life mean to you?
Living a genius life means sharing your expertise. Beautifully put. Well, thanks for coming out. Thanks, Max, so much for having me. So fun. Guys, pick up Little MisDiagnosed. And that's it. I'll catch you on the next episode. Peace, everybody. Hey, if you liked that video, you need to check out this one here, and I'll see you there.